Welcome to today's planning workshop. The purpose of this short PowerPoint is to offer you background information and a high-level summary of key activities of the Hume Region Chronic Care Steering Committee. The intent is to share with you emerging regional priorities so that together we can reaffirm strategic directions and commitments towards advancing best practice in chronic care. To provide context, it seems appropriate to start with a health report. 50 years ago, the burden of ill health, disability, and death were primarily attributed to acute infectious diseases. No longer. Today, the culprit is chronic disease. Which chronic diseases are we talking about? Just over a decade ago, Australia's National Chronic Disease Strategy identified the lead offenders as cardiovascular diseases, cancers, asthma, diabetes, and musculoskeletal conditions such as arthritis and osteoporosis. Fast forward to the present, and the lion's share of the burden still sits with these major diseases, although there appears to have been some shifts, such as towards the lower respiratory diseases such as chronic obstructive pulmonary disease that are now included in the lineup. It should be noted, lead authorities such as the Australian Institute of Health and Welfare highlight chronic diseases can be categorised either in terms of cost, prevalence, death, demand, and burden. Depending on categorisation approaches and reporting preferences, the view changes. For example, with respect to deaths, the biggest killer in 2010 were cancers as a group, whereas in terms of cost, cardiovascular diseases and oral health were the most costly. And from a total burden perspective, musculoskeletal disorders were the largest contributor, followed by cardiovascular diseases and mental health conditions. The diverse categorisation options flags an important consideration for us. In the Hume region, what is actually our preferred approach? So why the rising prevalence of chronic diseases? In Australia, an ageing population and changing lifestyles are considered the primary drivers. In relation to age, nearly all people aged 65 and over are reported as having at least one long-term condition, with more than 80% of people in this age group having 3 or more long-term or chronic health care conditions, compared with children who sit at 27%. Lifestyle behaviours such as smoking, physical inactivity, poor nutrition, and harmful use of alcohol are considered common underlying causes and risk factors. At a regional level, in addition to the primary chronic health conditions already mentioned, key health issues, as identified by the now defunct Medicare local organisations, that's Hume and Goulburn Valley, they included obesity, mental health conditions, including suicide, oral health decay, and lifestyle behaviours, smoking, drugs, and alcohol as key priorities and areas of action. Comparable to national trends, asthma, arthritis, cancer, and cardiovascular diseases are, according to both organisations, health issues that require a system-wide approach to effecting quality improvements and changes. If we are to be true to the principle of person-centeredness, it stands that in all our activities we are informed and led by consumer needs and wants. Recent research offers us some keen insights. The financial burden of chronic illness, compounded by poor communication, transport and access issues to appropriate, timely and quality healthcare, creates as much stress as the primary illnesses. Second insight, a high proportion of consumers have more than one disease. The confused, contradictory messages given by healthcare providers which focus typically on individual diseases, are in fact major barriers to self-management. And the third insight, consumers feel the health sector does a poor job in giving people usable information to help them understand and manage their conditions. Too much indigestible information is given with little follow-up. What does industry experience and the literature tell us? We need to put chronic care firmly on our respective agendas. Chronic care consistently appears to be implied within strategic plans. 2. We need to agree on uniform performance measures and sustainable data collection processes that will support our quality improvement goals. 3. We need to foster interprofessional collaboration and practice. 4. We need to consider building frameworks for ongoing sustainable chronic care quality improvement activities. We need to focus on improving access and a more systematic focus on prevention. And the last two considerations, we need to focus on upskilling our workforce to align with best practice chronic care competencies in both workforce and training arenas. And lastly, but ever so importantly, we need to engage clients. Here what we mean is that we need to ensure that the consumer's voice is heard resoundingly through all our activities. The Hume Region Chronic Care Strategy was developed in response to the National Chronic Disease Strategy's call for affirmative action. The vision of the strategy is that people with chronic health conditions in our region have access to high-quality services that work in partnership to provide person-centred care. Our target audience are people in the region with chronic health conditions that may have early stages of disease, established disease, or who are living with complex and or multiple conditions. The strategy identified a number of priority diseases, including diabetes, asthma, cancer, heart, stroke and vascular disease, osteoarthritis, rheumatoid arthritis and osteoporosis. The strategy is built on 4 principles, and they include access, appropriateness, efficiency and effectiveness. I won't go into those any further because I'm sure that all of you are very familiar with those principles. The objectives were built on several strategic platforms, and they are as follows, although I will just point out I understand that they're not necessarily presented in order of priority. The first strategic platform is to ensure that we adopt the National Chronic Disease Strategy and the related service improvement frameworks in all local services in order to support consistent evidence-based practice. The second strategic platform concentrates on developing agreed service pathways and capability frameworks for chronic care service delivery across the care continuum. The third platform is to consider and ensure that we embed self-management approaches in all aspects of care. And of course, providing clear and consistent information for people with chronic conditions and their carers is also an important objective. The fifth objective considers maximising information technology opportunities, and of course moving to number 6, which is critical, is aligning workforce development and capacity. And the 7th, which is a bit of a favourite, exploring opportunities for new and innovative models of reporting and funding so that we can demonstrate improved care and outcomes. Working on behalf of the Hume Health Services Partnership, the committee was formed 3 years ago in response to the growing impact of chronic disease in our region. The committee's charter is to support and improve the way chronic care is delivered by promoting a collaborative environment with all relevant stakeholders, including public and private providers, the client and their families. A key focus of the strategy is implementing evidence-based approaches and building an environment for the delivery of person-centred care. The overall aim of the steering committee is to provide leadership and strategic direction in the development and implementation of the Hume Regional Chronic Care Strategy. The current collaboration brings together senior clinical planning and management representatives from across the Hume region and the Department of Health and Human Services. And we could suggest the committee is a demonstration of the region's commitment towards ensuring people with chronic health conditions have access to high quality services that work in partnership to provide person-centred care. The Chronic Care Steering Committee have undertaken a number of major projects since its inception, starting off with some research projects to inform strategic planning. These have now been completed and the emerging recommendations were quite clear. We need to look at how we can improve access for priority diseases. We need to build our workforce capacity. We need to consider how we strengthen care coordination and multidisciplinary care. And then we also need to look at how we build stronger client education and self-management capacity. More recently, some additional discussion papers and studies have started in the dedicated area of workforce capacity. In particular, two discussion papers, preliminary, have taken a considered look at the current practice and regional experience in regards to professional development in the chronic care space, and also a second paper being tabled currently provides a review of the current chronic care competency models as experienced by a number of organisations from across the globe. From these two discussion papers, there are some very clear emerging themes, and they include that the evidence suggests we need to consider or determine shared competency standards in chronic care. We also need to advocate for interprofessional education and learning approaches. Apart from the research projects that the committee have committed to, they have also been instrumental in establishing the Hume Diabetes Service Improvement Collaborative. Formed in 2013, this particular collaborative have been instrumental in making some significant inroads within the arena of supporting organisations to improve the quality of diabetes services. In 2015 and 2016, moving forward, the collaborative have now determined 3 core goals that it will pursue, and they are: 1, to support application for National Association of Diabetes Centres in each primary care partnership area. 2, the collaborative as a group will focus on the quality of data and performance measurements. And 3, being mindful that we need to become more person-centred, the collaborative will seek to strengthen the consumer share of voice by improving health literacy and by building self-management capacity. This slide offers you a visual depiction of the key identified issues, opportunities, and priorities emerging from a number of regional needs analyses, research and quality improvement audits such as the Hume Region Assessment and Chronic Illness Care Surveys, or commonly known as ACIC. The horizontal axis shows the potential impact on the Hume Region Chronic Care Strategy, and the vertical axis depicts the relative importance of these identified issues to multiple stakeholders. As you will see on the far right quadrant, we can now see which issue or action priority has been identified high in terms of importance to many stakeholders, and also ranks high in terms of the success of the strategy. Given the number of studies undertaken over the past, in particular, 3 years, to make it a little bit easier for you, the years are colour coded and the icon legends are listed on the far bottom right. The icon legends have been formed into those core clusters based on the emerging themes that are repeatedly emerging from the various studies. It's appropriate to perhaps spend a little bit of time just giving you a high level view of some of the key insights that came out of the ACIC survey that our primary care partnership colleagues conducted across each catchment region. And this was done only a few months ago, in late October of last year. To give you a sense of the reason why this particular survey or audit could be of potential value to us in our strategic thinking, of the 25 publicly funded healthcare organisations, 21 of those actually participated in this audit. So that actually this audit represents the perceptions of 84% of all our potential funded healthcare organisations in the Hume region. From this particular audit, we actually had 11 quality improvement plans at both organisational and practice levels emerging, plus also our primary care partners also developed supporting catchment level plans. A general review of those quality improvement plans have actually clearly suggested some quality improvement themes that may potentially be the frontline chronic care priorities, or at least for you to consider. And they are as follows. Over 80% of all participants flagged their intent to concentrate on infrastructure, processes, and delivery system quality improvement activity. Common areas were care planning and refining processes, especially those that related to registry intake, admission, and discharge. Should also note a high proportion of process-related improvements will focus on diabetes, given they need their desire to align with the chronic care strategy's chosen targets. I leave you with the following themes and recommendations captured during the Steering Committee's recent review process. And thank you for listening to me. My name is Karen Wilcox and I am the Chronic Care Project Lead. And I will now hand you over to Jackie and Janet, who are going to lead you through a breakaway session. Cheers for now.